Life is complex, so is our mental health. It cannot be understood by diagnosis alone. Our philosophy is treat the person, not the mental illness. Hello everyone and welcome to another episode of Humanizing Mental Health. I'm Trent Nickers.
And I'm Jeremy Alcorn.
Well, today on the show we're going to be doing a good old question and answer period, I believe.
Yeah, like we don't even actually know exactly what we're going to be talking about. This is going to be a little bit of a mystery box. Amy is with us today.
Hello.
And she has some common questions that people have about mental health disorders, about wellness, relationships. And so we're gonna do a little bit of question and answer, like you say, Trent.
Yeah, and unlike question period in the House of Commons, we're actually going to behave with each other.
No one's going to be banging desks or calling people down.
Absolutely. So, on that note, hit us with the first one.
All right. The first FAQ question is, what are some of the most common mental health disorders?
Ooh, okay. So that one may not be much of a surprise, but some of the most common mental health disorders, and I want to put a little asterisk when I say this, because the thing is that what qualifies as a disorder and it does not qualify as a disorder really comes down to the Diagnostic and Statistical Manual, because for a lot of us, we can experience a lot of these issues. It's about whether or not when it becomes clinically significant. So some of the most common ones, of course, are anxiety, depression. I think anxiety and depression are the two most common. What are some of the other ones there, Jer?
Yeah, for sure. Like when you think about the most common disorders, you're correct. Anxiety and depression. In fact, what we know now from health population studies that have been done is that by age 40, 50% of Canadians have experienced a mental health concern that has been significant enough that it's considered mental illness. And most of those are depression, anxiety, for sure. The ones that people often hear about as well. Bipolar disorder is a very kind of well-known and talked about. I think often people don't actually understand it well, but and schizophrenia is well known. So there's a number of different conditions that are psychotic disorders. It's not just schizophrenia, but schizophrenia afflicts 1% of the population, which is a fascinating thing. Fascinating in terms of as a comparison point, because you see a bunch of the other disorders have, in terms of the number of people experiencing them, has actually increased very significantly.
Yeah.
But schizophrenia has remained 1% of the population for as long as it's been studied.
Mm-hmm. And I mean, there again too, if we're going to talk about disorders, we also have to look at it from how are we understanding disorder? Because if we were to look at certain mental health disorders from a cultural lens, certain things would be considered more common than not. For example, in certain circumstances with something like schizophrenia, if you were to be hearing voices and different things like that, having auditory hallucinations, if you were to look at that more back in terms of like the Middle Ages, if you were to be hearing the voice of God or angels or something of that nature, that wouldn't necessarily be classified as a disorder, but that would actually be seen as something that may be quite vaunted and actually looked after.
Or even, I was having this conversation with the base surgeon at CFB Suffield, and he was talking about these people likely being taken under the wing of a shaman, that when it was identified that they were having these kind of experiences, that they were likely an acolyte to a shaman who would teach them how to appropriately connect with what they saw as spiritual experiences, and how they could be a guide for other individuals. So totally, I agree with you.
Yeah. Also, I want to say, if people want further information, because we're only going to be giving a post-stamp size answer in some cases, if you want further information, please feel free to reach out.
Yeah, absolutely.
You ready for the next question?
Yep.
How does medication help in treating mental health disorders?
Do you want to go start with that one, or do you want me to start off?
You can shoot. Go ahead.
Okay. So really, well, basically, in a nutshell, like every medication works differently, but what it can really do is that it actually works on the neurotransmitters in the brain, and it will either help to inhibit neurotransmitters going across the synaptic cleft, or it can, which will actually increase in some cases the level of neurotransmitter. For example, selective serotonin reuptake inhibitors, because with for those individuals, they would use that predominantly in the treatment of depression, because with greater serotonin staying in the brain longer, what it will actually do is it will help people to have that greater long-lasting effect, or in some cases, it can actually slow the production of certain neurotransmitters as well.
Yeah, the only thing I would add to that part is just remember actually that the majority of the serotonin is created in your gut. We consistently say brain, and brain is important as well. It's just that that often it's been conceptualized as a brain condition, depression, and it's like a whole body experience, and those synaptic processes happen through the gut, through the heart, through all of your synapse in your body. Mm-hmm.
Right, and I'll even add to that where, like when we're talking about medication, if you're looking for really whether or not the medication will be effective, medication is not something that can really turn off and on like a light switch, but really what it is it's more like a dimmer switch, in the sense that it will slowly ramp up, and it's about finding the right effect for you, and for many people that I believe can take anywhere from 1 to 4 months for them to really see the long-lasting effects. Of course, depending upon an individual's individual biology and other things that are going on at the time as well.
Yeah, like in terms of the antidepressants, you're looking at a minimum of 2 weeks before you're finding a therapeutic effect. Usually they start the medication low and move up to a therapeutic dose so people don't have a lot of side effects. So minimum of 2 weeks, sometimes up to 6 weeks before you're really starting to feel the effects. And then you're correct, over a very long period of time. So a mistake that people make is that they get feeling better in 3 months and then they stop taking their medicine. Mm-hmm. I'm not saying you need to stay on it forever, but if you're going to commit to medicine as part of your mental health treatment, you want to invest about 1 year's worth of time into that, because if you go for a year that you're feeling better for this long extended period of time, then the likelihood you're going to fall back is way less.
Yeah, I like how I describe it to a lot of people in some ways. With medication, it's like putting a stick in a window. And like when you have that greater window of tolerance, that will help to encourage physiological changes in some respect, and that also gives people the opportunity to gain insights and skills to add to your toolbox, so that you're not just using the medication all the time as a crutch or something to hold the window open.
Yeah, like I like the comment you made there, crutch, because that's what medication in these cases most of the time is. It's a crutch. People say, oh, that's just a crutch. Well, no, if you roll your ankle needs to be supported until such time as it can hold itself. Mm-hmm. And that's the point of medicine. Medicine cannot cure people. That's not how it works. It's intended to give you a lift so that you can do the things you need to do.
Absolutely. Yeah. The body heals itself. We're just providing it the right environment.
Yeah. So I want to also just talk a little bit about some of the other medications to go in a bigger, broad, sweeping category of what's used in mental health. So you've got classes of medicines that are antidepressants, and they're typically used for sure for depression, but also for anxiety, depending on which ones. They don't all simply work on the same set of neurotransmitters. There's classes inside those classes. Mm-hmm. So you have those selective serotonin reuptake inhibitors. You have some that work on serotonin and norepinephrine. You have some that work on dopamine and norepinephrine. And each one of these has a little different process. Some are more activating, that kind of get you up and moving, and others are more sedating. And then you have a very old class of antidepressants called tricyclic antidepressants that work on three and they were very emotionally numbing when they were at the therapeutic dose. You also have a class of medicines that are used for mental health that is the anticonvulsant class. So it causes mood stabilizing effect. I can't say that I understand why. Just simply that it works on the central nervous system, that the nerve pathway that is associated with epilepsy. And then you have what's in use today, the atypical antipsychotics, which are a new class of antipsychotics from about the 1970s. And they function where some of those other medicines are very specific on what transmitters they're hitting. These ones actually are hitting a large number of neurotransmitters and tend to then get the brain to and body, guts, heart to slow down, stop racing.
Yeah, and I almost think that I'll use an example here from actually The Dark Knight, because they always talked about the Joker and the fact that they thought that he was possibly a psychiatric patient because you could see with him that he was always licking his lips. And when we talk about that, I want to bring that up specifically because when we're looking at psychiatric medications, when people are going on them, I think it's also really important to think about some of the side effects that can come with that, because there's positive and there are negative things that it can bring about for people. And when I say negative, it would just be things that you need to take into consideration. So if one medication doesn't work for you, there may be other medications that have more or less side effects depending upon things.
Sure, and most of those side effects, not all of them, but most of them will diminish within a few days to a week or so. So it really is a investment. One last one that I would mention is a class all its own, which is lithium. And lithium is a true mood stabilizer that is kind of the gold standard of treating bipolar disorder, but it does bring about potential internal organ issues. So they keep a close eye on them doing blood work consistently to make sure that it's not causing damage. So that's why they don't go to lithium immediately. But yeah.
All right. The next question is, what are some online resources for mental health support and information?
Well,
Humanizing mental health.
Yeah. Thank you. Shameless plug for us. Yeah. There are actually, I think that this is almost a broader topic that we could probably talk about in a future episode. Whereas, how do we distinguish good or quality online mental health supports? And first of all, like some of the best ones that I would probably mention would be go to your government resources, Government of Canada, Government of Alberta. For myself personally, I use actually a lot of the armed forces websites for things in terms of PTSD. There are Psychology Today, I would say, is an excellent resource if you're looking for therapists. And if you're looking for other things like that, I would say things, even though I don't want to plug them, just because I'm a business owner myself, stuff like BetterHelp, things like that would also be an excellent resource too as well.
Yeah, totally. And the one thing that I would add is the Center for Clinical Interventions, which is out of...
isn't that Australia?
No, New Zealand. There we go. Sorry, Australians, if we upset you, or New Zealanders. So it's out of New Zealand. It's through their government public health system, and it has a whole bunch of cognitive behavioral therapy workbooks from panic attacks to social anxiety to depression, health anxiety. There's a whole number of resources in there. Yeah,
and a great self-help one to be used in conjunction with your therapist that I use quite frequently on boundary setting is excellent too as well.
You mean that from the Center for Clinical Interventions?
Yes.
Gotcha.
All right, the next question. How can we reduce stigma surrounding mental health?
I would say the best one for that would be like what we're doing right now, which is talking about it, providing information, humanizing mental health so that people are not just seen as the diagnosis for it, and that we're viewing it within context for the individual.
Yeah, like for since about the late 80s, 89 is when Prozac came out, one of the new classes of antidepressants. And from that point in time, there had been a big kind of broad health philosophy that is mental health concerns are caused by a chemical imbalance. And that was, I think, an attempt to help to destigmatize it. It's like, oh, would you feel stigmatized if you had diabetes? And that's the comparison that was often made. That has actually been debunked, that there's no evidence that shows that mental health concerns are caused by a chemical imbalance. Chemicals are certainly involved in it, but that they cause the condition there's just no evidence that says that's true. So the trouble is that while we're trying to destigmatize it, what we've done is we put people into a place in which we've said, well, the only thing that really is going to make a difference with this is medication. And that's absolutely not true, that medication is the only thing that will help. We've also put them in a place in which it's like, this is just something you have to accept. You have to accept that you have depression, and that it's in your chemicals, and that's not helpful either. We don't actually have to accept that we have depression. 80% of people get better. So almost everybody, with a large majority, or I don't know about majority, but a large number of those people never even seeking help. So I think part of the getting rid of the stigma is to be able to recognize that this developed for a reason, and that actually we see it as a disorder, but realistically it's probably actually survival skills that you developed. And so being able to say there's a function that this is playing, and it's also costing you something, and we need to find a new way of relating, because this cost is not worth it.
Absolutely, yeah. We can look at that. We've mentioned that several times on the podcast. I don't know, was that a personal conversation between you and I where we talked about internal schemas and changing the rules?
Yeah.
I wonder if that's one that we should bring up right now. Because like we can either look at this from like a parts perspective or an cognitive schema, in the sense that our brain is an association machine, and it will create an internal set of rules for how things go. And like Jeremy was just mentioning, that can be really helpful because it can help in that quick reaction. But sometimes it's about looking at that internal set of rules, and if you're going from a Gestalt perspective, bringing in the judge and kind of saying, do we need to relitigate this and say, is there an exception that needs to be created, or do we need to throw this rule altogether and put some new internal policies in place?
Yeah, and the one thing I would add too with that is remember that these rules were being built before the last part of brain development was complete. That the biggest portion of our protocols or rules, whatever you want to call them, occur during our key developmental phases, which is 0 to 6, and then there's only one other time that you go through dramatic physical and emotional growth, and that's in your teenage years. So the front of your brain's not developed at that point in time, and the rules are actually being encoded in a deeper level of your brain. It's not in the part that the cognition is in control of. So being aware of that then it means that mature brain needs to come back to look at that immature part of their brain that is actually the part that's holding the rules. It's like we're being governed by a teenager rather than our adult self.
What is that book that you often reference that maybe we should have another podcast on? I'm coming up with ideas as we're having a podcast. But Hold On to Your Kids.
Oh, yeah.
Yeah, we should definitely sit down and have a good, longer discussion about that.
Yeah. Why parents need to be more important than peers.
Absolutely.
All right. How does mental health differ between children, adolescents, adults, and older adults?
Well, I think that there are a lot of things, a lot of commonalities in terms of like anxiety, depression, different things. It's about presentation. I think sometimes it's about age of onset, and then for us as practitioners, it's also about how do you approach that, the interventions that you predominantly use. Like I would say that almost everyone across the life cycle can get the very common ones, such as anxiety and depression, but things such as schizophrenia and all that jazz will have an onset around in about your early 20s. Anyone can experience trauma, as we've mentioned. At at any age, and I think it's about what really they're needing at that time in terms of, for some people it could be support, some people you can use cognitive interventions, and for some people, especially for younger individuals, you may want to go more specifically direct to a somatic approach because of their brain development at the time.
And by somatic, you mean?
Sorry. I'm getting into technical language. Somatic being like body-based approaches, helping them to feel their feelings, or even in some cases as the therapists themselves, helping them to name their feelings. And that may even be important for older people too as well, because they may not have grown up with that and they may be disassociated from that on some level.
Yeah, one of the things I would add to that is I think Erikson's theory of development is actually really helpful with this conversation. So Erikson pushed back against the idea that all of our development is completed at a certain point in our life, but that there's developmental phases that take you all the way to death. And there's physiological changes too. So like an individual that is 80 years old, their metabolism is different than an individual that is 20. So even in treating that with medication, then that metabolism changes will be critical. I also think that we could come back to interpersonal neurobiology with this and go, what happens in these phases? Where is it that I develop my relationship with myself? But then how does my tribe change over time? Who I'm connected with?
Life transition.
Yeah, because when I'm in my teens or 20s, that may be that I'm playing sports, and that's a big part of my process. For that individual that is super connected to sports, well then when they're 60 or 70 and they're slowing down and they can't do the things that they used to, they may go through a really crushing feeling of loss. And for everyone, I think that's a common thing. As we age, people in our tribe die. Our ability to connect to our earth changes. And I think all of those things make a difference in how we are in our mental wellness.
Yeah. Have we done a podcast on life transition?
I don't think we have, no.
Okay. Amy, are you writing these down?
No, but I mean, this is being recorded, so.
Fair enough. Okay, so you know what your job is after today is you're going to go back and re-listen to this podcast.
Yeah.
Any hoodles.
All right, you ready for the next question?
Yeah.
What are some strategies for supporting a loved one with a mental health disorder?
Honestly, I would say first and foremost is you want to really work on your validate skills, whereas, it's about listening to them, turning towards them, asking them open-ended questions, and making sure that they feel heard. I would also say really helping them to name their feelings, coming up with things, and then helping get them to proper supports.
Yeah, and keep in mind, of course, that one of our biggest predictors of our wellness is our connections with other people. So an individual that has a significant depressive disorder may often want to isolate themselves. And I think part of that isn't like saying, hey, you got to stop this. You got to do some stuff with this. You got to stop isolating yourself. But it's actually about continuing to invite them. Do you remember, Amy, I think you showed me this post that was about the Winnie the Pooh, like the 100-Acre Woods. That was about Eeyore.
Oh, yeah.
Do you want to share that?
Well, my brain's a bit foggy, so I might not get all the details correct, but I saw this post that was about Eeyore from Winnie the Pooh, and of course, he kind of represents like more of a depressed character. And the thing is, none of the other characters in Winnie the Pooh like criticize him for being depressed. None of them like make fun of him for being depressed. They accept him for who he is and invite him to participate in whatever fun activities they're doing and give him the choice to participate or not. And no matter what he chooses, they're okay with his choice. And so that type of support, like when I saw that post on social media, I was like, wow, that's like really supportive. We should try to be like the characters from Winnie the Pooh.
Yeah, absolutely.
Yeah, I love that. Thank you. And that makes me think of your 100-Acre Wood gang.
I did a video presentation in university. It was a group presentation that we're supposed to do. And so myself and a couple of other students put together a video in which we used stuffed animals as a representation of someone being recruited into a gang, and the gang they were being recruited into was the 100-Acre Woods gang.
So I wonder, if we look at that, like maybe like was Eeyore the one that was technically the new one in your 100-Acre Wood gang?
And the funny thing is that we used a character that probably within the story would have been the most vulnerable. It was actually Piglet, because Piglet is full of fear, right? Full of anxiety. And that sense of we're going to protect you. You don't have to worry about the world. You can be part of us, which actually goes right back to interpersonal neurobiology. Why do people actually connect in gangs? Because they need community. They need to be a part of something. And it's an unhealthy way of doing it. But
I'm wondering there, because like I told you, I was reading a book over the weekend, or started reading a book on specific types of trauma, and it actually went back through the cycle of trauma. And I almost think, again, longer conversation, but where we look at the cycle of trauma and how it actually weaponizes our need for community and our need for connection.
Yeah, because that's exactly the right way of saying this, right, when it comes to youth gangs. And what the world has come to know as toxic masculinity, which I don't think that there is a gender that's toxic. But but that's it. The sense of shared language, the sense of shared body language, how they represent themselves, colors that they wear to show who they're connected to. So, yeah.
Fascinating. Moving on.
What are some best practices for promoting mental well-being in the workplace?
I would definitely say, it can really depend upon the workplace itself. But I think what it's about is it's about trying to influence. If you're looking at it from an individual perspective, that's different. But if you're looking at it, because we've talked a lot about individuals, I want to look at it from more of a broader, more of a micro or macro or meso perspective. I think what this really comes down to is it comes down to looking at the overall culture of the workplace and how can we make people feel connected and valued and heard, and where it's about encouraging people to be able to share their opinions, having policies in place that discriminate, or I shouldn't say discriminate, that encourage people to have sick days, mental health days, but then also allow individuals to be able to share their feelings, and to be able to also set healthy boundaries too as well. So that even if you have a hierarchy and even if you have a boss, that the boss respects the worker and the worker respects the boss, and that everyone is able to share their feelings and know their limits.
totally. One of the times in which I would say that actually the Canadian Armed Forces is ahead of the curve in this. They recently had put out training for all medical staff that was trauma-informed care, so that everything that we've been talking about becomes implemented within the medical process that is that is for those service members. And another thing that I have found is an organization like the military. I have this opportunity to be able to reach out to what would be in the regular civilian world, people's employer. Clearly, I don't breach confidence. But at times when there's like, there's a whole bunch of people that are all coming from the same unit, then we go, that's actually a population health issue. What's going on there? And to be able to then go and have a conversation with their chief warrant officer, the captain that's involved, and to be able to say, hey, we're wondering what's going on. We would like to support you in your process, in your leadership, because usually leaders are in a place in which they're struggling when they are having all these concerns that are going on. And so that's one of those times I think that it shows where organizations can make a difference in their processes. I wish it was more like that in the civilian world. Easier, of course, in the military, because I know their leaders. We have contact with these people even in Medicine Hat. It's not a big city, but even in Medicine Hat, I have to be more careful about how I approach a doctor, because the doctor doesn't know me, and they certainly wouldn't be interested in me telling them what to do in their treatment plan.
Wow, sometimes, dude, I can't imagine, what it would be like for you, having that level of knowledge and not flexing your expert muscles. Honestly, I just because sometimes around here at Synergy, like you and like a lot of us, especially when we do team meeting like we're going to do today, a lot of us greet you with a level of deference, and because of your skill and your awareness. But I can imagine that a doctor would be very taken aback at times.
Could be, yeah. And it's really great in the military, because I just go and I speak with the medical officer, that we know each other well, and I just say, hey, I wanted you to be aware of this particular thing that's happening, so that it can inform you in the treatment plan. And sometimes as a doctor coordinates, sometimes he doesn't even actually see the patient then, because there's that level of trust to come back, and for me to be able to convey some changes, like the doctor's like, okay, this person needs to have 2 days off, and then I go convey that, and the doctor sets it up so that it's taken care of. But
excellent.
All right, we have 3 questions left on the FAQ list. So, how are mental health disorders linked to substance abuse and addiction?
Well, what I would say is that the very postage stamp way of looking at this is that addiction is really a person trying to self-medicate, self-treat for their mental health disorder depending upon certain circumstances, because they're experiencing these issues, and they're looking for a way to either numb or to disassociate from these challenges. So in some cases, they go towards things like alcohol or illicit substances, food, or even working out as a way to manage these things, so that they have a sense of control in some respects.
Yeah, I'll try to make this really quick. So there's 3 experiments that really speak to this. The first one is you put a rat in a cage with a bottle of water and a bottle of heroin water. Every single time, close to 100% of the time, that rat will overdose and die. And so they came to a conclusion that addiction is caused by chemicals. But only actually about 10% of people that use substances end up with an addiction. So that's actually not true. So then someone else came along and went, the rat can either feel trapped, anxious, and depressed, or can use heroin, because it has no way out of its cage. So then all of a sudden this behavior makes sense.
Mm-hmm.
So what they did is they created Rat Park, which is a place that rats could run around in tubes. They could play with balls. They could play with each other. And they also put heroin and a bottle of water and a bottle of heroin water in there. And almost all of the time, none of those rats use compulsively. None of them overdose and die. There was another experiment, though, that someone went, but I wonder. And what they did is they caused an attachment injury in a baby rat by taking it away from its mother when it was first born. You grow that rat into adulthood. You put that rat into Rat Park, and that rat will actually overdose and die almost every time. So if we recognize that actually the use of whatever addiction that is, whether it's shopping, exercising, working, heroin, whatever it is actually that person's solution to whatever internal thing is happening for them. It's something that harms them in the long run. But clearly there is an underlying mental health concern in addiction.
I wonder, and maybe this is belaboring the point a little bit, but I wonder if you could use a similar lens with that to understand the Harry Harlow experiment as well.
Oh, speak to this.
So the Harry Harlow experiment is where they had, I believe it was rhesus monkeys, and they separated them from their mothers. And there was one where they would go and they had two different types of creatures in order to get a wire creature in order to get milk from, and then a cloth creature that looked like their mother that had no sustenance. And what they found was with the cloth creature that they tended to spend more time there and would only go to the wire mesh when they absolutely needed to.
Yeah, that does sound very relevant.
Yeah.
All right, 1 second. I'm trying to choose. How does physical activity impact mental well-being?
Okay. So physical activity can impact mental well-being in the sense that you can get a lot of oxytocin, serotonin in the brain, or not oxytocin. I guess you could get oxytocin in some sense, but you get a lot of serotonin. Endorphins, thank you, in the brain. Basically, all of your happy chemicals coming up, which will, of course, give you a greater boost in terms of overall feeling of mental health. Like this is where, as we were talking about at the beginning of the episode, where we have medications that will help to keep the serotonin in the brain. This will actually help to encourage more of it to be produced. And along with that, you get some feeling of grounding in your body. This can also help to discharge any trauma that can be held on the nervous system. And if you're doing physical activity in a group or doing a type of sport, this can actually be really good for peer bonding too as well.
Yeah, totally. You hit all, I think, the major things. The only thing I would add to that is, as you talk about endorphins, remember that endorphin gets its name from morphine. They knew more about opiates than they did about the human brain for a long time. And when they found this substance in the human brain, they were surprised. We have morphine in our brain. That's why they call it endorphin. So when someone goes and they get a runner's high, it's not a metaphor, it's real. It's actually the endorphin process naturally generated in our body for those painkillers, but it's also a very connecting experience. So that's really useful. Actually, we'll mention one other thing, and that is movement is important for your guts. And your guts are essential in terms of the you being mentally well. Like I said, more serotonin is made in your gut than your brain.
Absolutely. And I want to also actually add one other thing to that too, is that actually through movement, because of the way that human beings have evolved, that can actually encourage neurogenesis and neural connections to form. So if you're actually wanting greater positive association or to integrate what you're either learning in a class or learning in therapy, one great thing to do would actually be after therapy or after class to actually go through and to actually go and work out, because that can actually help to encourage those neurons to form.
Mm-hmm. So we got one more?
This is the final question. What are some of the major challenges in addressing mental health on a global scale?
Can I phone a friend?
Oh, I actually, the minute that you bring that up, I would say the first thing that pops out to me is culture, individual cultures, and because of how we view and understand mental health in a Western culture and the challenges that are there versus another country. So it's about being able to communicate and not looking at things from an ethnocentric perspective, in the sense that we don't want to invalidate where people are coming from or try to put our own perspectives on how do we address this mental health issue from, let's say, a Canadian perspective, if I were to be dealing with somebody from India, for example.
Yeah, as you say that, what jumps into my mind, I think the theme that you're speaking to is decolonization.
Mm-hmm.
That we have this central value that has been placed so firmly into concepts of money and about ownership and a lot of things that really come from one specific value set. And that's a big picture process. Like being able to have a society that truly is there for all. Yeah, I think decolonization is a really major part of that.
Yeah, and Amy, I don't know if you want to speak to this, but you told me about this recently, the concept of cultural humility. Do you want to tell our listeners about that?
Yeah, it's a new thing I've been learning in school. So in social work, I feel like this is something that's recently changed, because throughout my social work years, we've learned about cultural competence, which is basically the idea where we learn about different cultures, we learn about their values, we learn about how they perceive different things they believe in. Just like this, kind of like as if it's, there's hard answers to things, as if it's kept in a box. But that's not how culture works. Culture is living, it's breathing, it changes. And one of the new things that I guess has been brought up is, instead of being culturally competent, as if it's some sort of hard science, that we move to cultural humility, which it's still important to learn about other cultures, but we need to be open-minded that, just because the majority of a culture might be a certain way, doesn't mean that every single individual is going to be that way. And we need to be open-minded that, especially when we're looking at cultures that aren't our own, we are not the expert of their culture. The people who come in to see us, our clients, they're the ones who know themselves the best. And we should be humble and open to getting to know how they live life and how they perceive life in the context of their culture. I don't know if any of that made sense,
No,
but
totally.
No, absolutely.
it's definitely a new thing, and I think it's needed. I think that's good.
Yeah, simply because I have worked with individuals that are from the Mennonite faith does not mean that the next person that walks into my office, I'm going to understand who they are. I still have to understand who that person is. And then you build this kind of codex inside you as each person comes in which you know more about who they are. And it starts with a place of, I think, curiosity. That is just I don't know. And so I want to make sure that as I ask questions, that it becomes not just about that person. It is about that person, but it's also about understanding how does this fit within your context of your life and the culture you come from.
Absolutely. I mean, I think really the major theme that we've been pulling out through all of these questions kind of goes back to the core, one of the core theories that are part of social work, which is the biopsychosocial perspective. Yeah, where in that a person is looked at from their biology, their social background, and and their own psychological makeup too as well. I had to make sure. I was like, did I mention psychological makeup? And I mean, from that too, like you can look at developmental level and different things of that nature. And this is really honestly what one of the major things that social work pioneered, and that makes this a unique practice in mental health.
Yeah, absolutely. I totally agree.
Yeah.
So pulling it together.
Yeah. Well, I appreciated going through all of these frequently asked questions, and I noticed that you and I really do pair well with each other. I kind of did the general, you did the specific.
Yeah. It's fantastic. I really enjoyed this episode as well, to be able to have just this open conversation about things without knowing exactly what we're going to cover at first. It really is stimulating to my mind. I hope that there's things that excuse me, I hope there's things that resonated as I have a frog in my throat with our listenership.
Absolutely. And if those of you who are listening, if you have further questions or want us to answer a specific question, don't feel free to reach out to us through our Facebook page.
And Amy, did you have any thoughts as we wrap up?
No burning questions, no. But those are all the questions I've already asked. But
sure.
I thought this was great.
Yeah.
Okay.
Very informative.
All right. Yeah. So talking about and what Trent was just whispering about. He was just reminding me to talk about synergy events. I know that there's a breath work that is just coming up. I know that our practitioner that's a massage therapist also does Reiki processes and yoga. And I know that there's some of those classes that are coming up. Is there anything that jumps out to you, Trent, to make people aware of?
Not that I know of, not at this point.
What about the students?
Oh, yes. Sorry, as we have one of them sitting here. Thank you. That we have students that are here to provide low-cost mental health services. That Jeremy and I are actually overseeing them, and that both Brooke and JD Ann are wonderful. And if you do get a chance to phone into Synergy, you may actually be talking to our wonderful Amy here too as well.
Yeah, absolutely. And so just a big picture on that. Like, we recognize that mental health services can be very costly, especially for people who don't have insurance. And so one of our ways of giving back is to have people that can give low-cost service, and we then volunteer our time to supervise them to ensure that the services they're giving are top-notch. So.
Yeah. But on that note, I'm Trent Akers.
And I'm Jeremy Alcorn.
See you next time.
Thank you for joining us today. We hope that this message has been as meaningful to you as it has been to us. If you're looking for help, you can find us on Facebook at Humanizing Mental Health.